Around the world, populations are aging rapidly. There is currently more than 1 billion people over the age of 60, representing 14% of the global population. By 2050, this population will have more than doubled to 2.1 million. Amidst the backdrop of the United Nations Decade of Healthy Aging, continued rise of non-communicable diseases, and in the context of vaccine hesitancy among the Canadian population, now is the opportune moment to discover and explore health promotion campaigns to increase awareness about vaccine-preventable diseases and inform the public about the benefits of a life course approach to immunization. My name is Anna Sangster, Director of Policy and Innovation at the International Federation on Aging. Join me for an exciting two-part podcast series celebrating and recognizing the immense importance of Shingles Awareness Week in Canada, which is from February 27th to March 5th. This series aims to increase our collective understanding and awareness of the knowledge gaps that exist among Canadians regarding shingles and shingles vaccination, tapping into clinical expertise and incorporating the invaluable patient perspective. Shingles, also known as herpes zoster, is a debilitating vaccine-preventable disease, which significantly impacts functional ability and quality of life. Older adults are at greatest risk of shingles, with the highest burden in those aged 50 years and older. Despite the benefits of shingles vaccination, awareness, access, and uptake remain startlingly low. For our first episode, it is my distinct pleasure to welcome Dr. Marla Shapiro. Dr. Shapiro completed her medical school at McGill University and received her Master of Health Science from University of Toronto. She concluded her specialty training in community medicine and received her fellowship in preventative medicine. In 2015, Dr. Shapiro was named a member of the Order of Canada for her contributions as a family physician and a trusted source of health information. She is currently a professor in the Department of Family and Community Medicine at the University of Toronto and is also a frequent medical contributor for CTV. She is a member of several advisory boards, including the Terry Fox Research Institute, and a best-selling author. Dr. Shapiro, thank you so much for taking the time to join us today. While I've tried to capture the many hats you wear, perhaps we can start today by hearing a little bit about the day-to-day work you do.
Well, day-to-day, I'm a primary care physician. It's work that I love to do. I have a fairly large practice. I'm active from birth all the way to my patients who are over the age of 100. And one of the most important things that I do, regardless of age groups, is primary prevention. And to that end, what we're talking about today is so critical because preventing a disease is much better than trying to treat a disease.
Absolutely, absolutely. Before my grandmother came down with shingles a few years ago, I had actually never heard of it before, which given her experience and what I've now learned is quite surprising. I'm sure I'm not unique in this experience. So perhaps to help kick things off, you can tell us a little bit about what shingles is.
So most of us in the age group 50 and older experience chickenpox if we were born in Canada or raised in Canada. And that's the primary virus known as varicella zoster. We got our chickenpox, we got better from our chickenpox, but the virus actually never left our body. That varicella zoster virus lies latent, asleep if you will, in our dorsal root ganglia, which is in our spinal cord. And then years later, for whatever reason, and there's a host of different reasons, and age primarily is one of the ones that we talk about over the age of 50, we see reactivation of the varicella zoster virus, and it presents as what's known as herpes zoster or shingles. So it's really that chickenpox virus that is woken up, it multiplies in that dorsal root ganglia, then it travels down, presents in the skin, usually on one side. We call it a dermatome, an area that's innervated by the nerve there where it's been reactivated. And it presents as a very painful rash.
So you've talked a little bit again about a kind of a painful rash. Can you speak a little bit about some of the other complications perhaps, or some of the other symptoms of shingles?
Sure. So we think about shingles often happening on the torso. It can happen in any nerve root dermatome, but it also can happen in the eye, and that's known as herpes zoster ophthalmicus. And that's reactivation of the virus in the ophthalmic division, the eye division of the trigeminal nerve, and that can lead to severe chronic pain, even vision loss, and there can be an increased risk of stroke. The most common complication that we see from shingles on the body or with herpes zoster ophthalmicus is postherpetic neuralgia. And this is persistent or relapsed pain that lasts more than 90 days after the onset of the initial rash. And for some people, that pain can last a lifetime and it can be a game changer. those are the common complications. There are less common complications that we see, but these are the most common complications that we see.
Wow, that seems like such a terrible experience. Why do you think, kind of despite the severity of the symptoms and the experience people have with shingles, that there's such a low awareness rate?
Well, firstly, most people don't think of themselves as being at risk. If you look at the lifetime risk of shingles in Canada, it's about 28%. However, in the eighth decade, and we're all living longer and healthier lives, it's not uncommon for me to see people in my practice over 80, 90, and I have a few in their hundreds. If you're 80 years or older, the risk of having shingles increases to 1 in 2. So nearly 2/3 of our cases occur in individuals over the age of 50. It can occur in younger individuals, particularly those who might be immune compromised. And for every 10-year increase in age, we see an increase of somewhere between 1.5% to 3% increase in the relative odds of developing shingles and postherpetic neuralgia. So the first thing is that you have to recognize that if you've had chickenpox, you are at risk. No matter how healthy you are at risk. So many people just don't perceive themselves as being at risk. And for that reason, it's not on their radar screen. In addition, many aren't aware that shingles is a reactivation of chickenpox that they've had, and that we have a very effective preventive strategy in vaccination. So I think it really comes down to education about recognizing what your risk is.
So we've talked a little bit about the symptoms of shingles, Dr. Shapiro. I wonder if you can talk a little bit about whether shingles is contagious.
So it's a great question because we think of all infectious diseases as being contagious. Certainly chickenpox is one of the most contagious diseases in terms of childhood illnesses. And now we have an effective vaccine for that as well. So when you have shingles, it's reactivation of the virus that was already in your body. So when you have shingles, no, you can't transmit it from an airborne point of view the way many other viruses are transmitted. However, in the vesicles, the blisters themselves is active virus. So if somebody who had never been exposed to chickenpox or hadn't been vaccinated to chickenpox was to touch the fluid in the vesicles, then it's possible that they could put themselves at risk. But in terms of being in a room with somebody, no, this is not contagious from that airborne point of view that you would think about with the primary infection, which is chickenpox itself.
Terrific. Thanks very much, Dr. Shapiro. I think that was an important addition to add there.
Yeah.
Great.
So.
So I think most of us can have experienced chickenpox in our lifetime. And luckily, chickenpox is something we only have to experience once. Is shingles something that you have to worry about if you've already had shingles?
For people who have had shingles, they often think of themselves as having had the disease and they're not at risk anymore. But in fact, that's not true. If you've had shingles, it does boost your immune situation for a while, but it doesn't give you lifelong protection. And in fact, if you've had shingles, it actually can put you at increased risk for another episode of shingles. So even if you've had shingles, we still recommend that you get vaccinated. And when you get vaccinated in relationship to when you've had your outbreak is a conversation that you should have with your healthcare practitioner. But generally, we talk about a year after the episode of shingles.
Right. Thanks very much for that answer, Dr. Shapiro. The next question I have is kind of, twofold. One, what are some of the kind of the early warning signs of shingles? And then on the other hand, what are some of kind of, I know you spoke a little bit about the pain being a long-term complication, but are there any other long-term complications that can carry over when you've had shingles?
So firstly, let's kind of divide that into two. So we'll take the second part first. The biggest complication for people really is that postherpetic neuralgia, that pain, but that pain can then translate into affecting your activities of daily living. So for example, some of my patients who have postherpetic neuralgia find that minor stimuli, like taking a shower where the water isn't that hot, may give them very ultra painful sensations. Cold weather may exacerbate their postherpetic neuralgia. So really, it can lead to the risk of increased depression and inability to carry on with our activities of daily living. And it really impacts on the quality of life. So I think it's really critical. And if you're listening to this, look at yourself and try and figure out, do I have anything else other than my age that puts me at increased risk? For example, if you're a diabetic, you have a 30% increased risk. If you have underlying heart disease, also any medication that leaves you immunosuppressed or a disease that leaves you immunosuppressed. With cancer, the risk is twofold: kidney disease, chronic obstructive lung disease, And what's really interesting is that if you have a family history, a first degree blood relative, that'll increase your risk about 2.5 to 3.5 times. And if you begin to have more than one first degree relative, that can increase your risk by 17-fold. We see it a little bit more in women than men. Certain ethnicities, Caucasian, have an increased risk versus non-Caucasian. So when you begin to sort of do the math and look at your individual risk factors, it certainly can contribute towards the risk of infection. And then the risk of infection can lead to postherpetic neuralgia. And that chronic pain can really change the quality of your life.
Yeah, I had no idea that just the degree of risk and kind of the diversity of different factors that could put you at increased risk.
Yeah,
I think
yeah.
one of the ones you talked about that I'd love to kind of dig into a little bit more is that age component. I think a lot of people are unaware that your immune system becomes weaker as you age, and that can then increase your risk of things like shingles and certainly the negative consequences from shingles. So I was wondering if you could speak a little bit to kind of the concept of immunosenescence and why older people in particular are at increased risk.
Okay, so the concept of immunosenescence, let's break that word down. Immune meaning your immune system, senescence meaning it's aging. So no matter how well we age, keeping fit, doing exercises, keeping up our core strength, all of those good things that we talk about in terms of diet and nutrition, really from the point of view of shingles, the reality is that we get older, our immune system gets older, and its ability to fight off infections does get lower with age. That's why I told you if you're over 80, your risk of shingles is 1 in 2 compared to a lifetime risk of about 28%. So aging is critical. It's not that we don't see shingles under the age of 50. We do, but not all that common. Certainly more common if you're under the age of 50, if you've had a bone marrow or a stem cell transplant, or if you had a solid organ transplant, or if you have an autoimmune disease, for example, like lupus, or you have rheumatoid arthritis or inflammatory bowel disease. There are a whole bunch of things that can increase the risk. But for the average individual without those immunosuppressive risks, while we do see shingles under the age of 50, we don't see as many complications in postherpetic neuralgia. It really takes off after the age of 50. And that is really so important because that's what really gave us the information that shingles was about a recurrence of a virus that was already in your body. So when we looked at studies that were done in Australia or Germany or France or Spain or Canada, you name it, anywhere in the world, the risk of shingles was relatively low in age 40 and under, but then takes off dramatically, increasing year over year as we age and as our immune system ages with us.
Thanks very much, Dr. Shapiro. You've talked a lot about kind of the physical pain and discomfort and potential kind of, the lifelong nature of some of those symptoms. I'm wondering if you could talk a little bit about kind of the potential impact that could have on your mental health.
Well, imagine living with chronic pain, and chronic pain that often is very difficult to control and involves what we call polypharmacy, meaning many different medications that are used to control the pain. And if you don't have your quality of life, if you cannot do the things you love to do, be with people, socialize, which is actually one of the biggest important features of aging well is social connectedness, it really can lead to really impacting your psychological status. And a lot of patients who live with chronic pain have depression and really feel that they can't carry on the quality of life that they would like to have. So, it's really a complication of the chronic pain state more than anything else.
I know Shingles Awareness Week this week, one of the themes is kind of missed moments. I assume kind of some of the mental health impact would come from potentially some not being able to participate in some of those main big life moments. I know that oftentimes the rash can be quite, for some very self-conscious about it. So I'm sure that that's a factor in some of that mental health as well.
Well, the rash itself, while visually, depending where it is on your body, you can hide it, so to speak. You can't hide the pain. You
Right.
can't hide the impact that pain has in terms of the quality of your life. And, there's other complications that we can see. We can see scarring at the time that you have shingles. You can get a bacterial superinfection, those ocular complications I mentioned. And, less commonly in an acute case of shingles, the virus can replicate, leading to brain inflammation called encephalitis. There can be pneumonitis, meaning inflammation in the lungs, hepatitis. Those are less rare, but that impact of pain and the inability to participate wholeheartedly in life because you're impacted by the severe, debilitating chronic pain, That's the most common complication that we see with shingles. And age, again, is the most significant risk factor. So, we get that prodromal pain. The pain appears. Usually it appears in a specific area, but there's nothing to see. And patients often aren't sure what's causing the pain. And then the pain gets increasingly severe. Then we actually begin to see these little blisters or vesicles. Now, this is really important because we know that our treatments are really not all that effective. And one of the reasons they're not effective is because we don't diagnose it quickly enough, because the infection starts with a virus replicating in your dorsal root ganglia in your spine. So you're not aware that's happening. That can take 24 to 48 hours. Then there's pain that could last for another 24 to 48 hours. And then the rash, and then there's actually getting in to see a healthcare practitioner. We know that if we don't get in within a 72-hour window, our therapies, our antivirals, are very unlikely to make a big difference. And we think about herpes zoster ophthalmicus, the one around the eye that I mentioned, as a medical emergency, something that has to be treated aggressively. So time is not on our side because often we have the pain without the rash, and often the diagnosis is not made until you visually see that rash in one clustered area of your body, that so-called dermatome that we refer to.
Right. So time seems to really be of the essence with shingles. I wonder whether, and perhaps this is a silly question, but I know you've said that the rash is often on one side of the body. Is the pain kind of located in a similar way? Is it kind of on one side of the body?
Yes.
And is that a way that people can potentially become aware of it and a warning sign for them?
So we typically think about shingles as being unilateral. It can be bilateral, but that's quite rare. So it's on one side of the body. It happens in an area that's innervated by the nerve that's being impacted by the reactivation of the varicella zoster virus. So we think about the thorax, for example, somewhere on the chest. And so, for example, one of the common areas is the middle of the chest on the right side or the left side. And you can have searing, burning pain in that area without the rash. And you don't really recognize that it is because shingles is about to erupt and that this is a diagnosis of shingles. So that early diagnosis is often missed, but certainly unilateral pain in a clustered area followed by the rash, that is really the hallmark of what we see visually. And historically, the pain precedes the rash.
So it's a great tip then for people, I think. I know that you kind of talked that, pain is one of the hallmark symptoms and complications, but you've talked a little bit about encephalitis, as well as I know that vision loss and hearing loss can be kind of some of the more rare but severe symptoms of or complications of shingles. Sorry. Can you speak a little bit to kind of some of those more severe complications and kind of, are certain people more at risk for those severe complications?
So those complications of motor neuropathies, meaning a motor nerve being impacted, or myelitis, or vasculitis, meaning inflammation in a blood vessel, or stroke. These things are really not all that common, but definitely are concerning. In fact, we don't think about mortality, but we do see a very definite but small mortality associated with this. So it may be related to the severity of the onset. Certainly someone who is more immunosuppressed is more at risk. But to put it, in perspective, the most common thing we do see is the rash and the postherpetic neuralgia. And it's really that impacts most individuals and really is a game changer in terms of quality of life.
So I think we've talked a lot about kind of how it's very difficult to catch shingles early. So I think we could agree probably that, vaccination is a really great prevention tool. There is a shingles vaccination, but uptake rates in Canada remain pretty low. Can you speak a little bit about, why you think that could be and what we could be doing to increase those uptake rates?
So in 2016, which is a while ago now, but that's one of the surveys that we look at, and actually it's gotten worse with COVID as people didn't see their healthcare practitioners. If you ask adults how many have received the recommended vaccine for their age and or risk group, so that would include, for example, things like influenza vaccines or pneumonia vaccines, the shingles vaccines, that number, you'll be shocked to know, is as low as 3%. Most individuals are not even aware of all the vaccines that we recommend to adults. So in that same national immunization coverage survey, many Canadians incorrectly believe they're up to date. In fact, 88% believe that they're up to date. But in fact, 97% have not received their recommended vaccines. And of vaccine intake, one of the lowest vaccine uptakes is actually herpes zoster. Tetanus is probably the best at about 69%, pneumococcal about 58%, influenza about 45%. And really much of this depends on endorsement by your healthcare practitioner. So many patients are not even aware of what vaccines are recommended in the adult period of time over age 50. And unless a healthcare practitioner brings it up, educates you, informs you as to why this preventive strategy is so important, many individuals don't uptake the vaccine. And often we think that cost is the blocker. Depending on which province you are, certain age groups are covered. But even if we look at costs, the reality is that when you ask physicians why a patient may not take it, they may think it's cost. But if you ask patients, patients will often say that the reason that they didn't take it is they didn't recognize the importance of having the vaccine, the benefit of having the vaccine, the fact that there was even a vaccine that was out there for them. So a lot of it has to do with communication about why vaccines are important, what it is that they can do, and why we're recommending this vigorously in terms of uptake. And we now have data looking at the present vaccine strategy that we have, and it lasts in terms of protection, in terms of data that we see between 10 to 15 years, and mathematical modeling maybe even longer than that. So it offers a long period of protection through the 2-dose vaccination strategy.
Fantastic. Thanks very much, Dr. Shapiro. Perhaps you can speak a little bit about the safety profile of the shingles vaccine.
In terms of the question of safety profile for the vaccine and side effects, the most common side effects that we see are local. So pain at the injection site, redness, and swelling, really quite common. Sometimes we will see muscle aches and fatigue and headache for a day or two, possibly 3, a sense of a flu-like illness having given people the vaccine. So I always let them know that that's something that can happen. But the majority of local and general symptoms usually resolve within a median duration of about 3 days. In terms of serious adverse events, so fever, being more significantly ill, that was seen in about 12% or so of individuals who got the current vaccine, but it was also seen in about 13% of individuals who received placebo. And while there may be even rarer side effects associated with this vaccines, for example, people talk about vaccines in Guillain-Barré syndrome, this is exceptionally rare. Really, the most common side effects that we see are local.
Fantastic. That's great, Dr. Shapiro. So perhaps this is a great segue to one of my final questions, which is really, what is one thing that you would want to tell people about shingles?
You know, every time I have a patient who says they don't want the vaccine, I turn around and I say to them, well, you're making a decision that it's okay to put yourself at risk and in harm's way. And they look at me and they say, I don't know what you mean. Well, when you say no to a strategy, that means you're saying yes to the risk of what it is the strategy is trying to prevent. And I want you to know that shingles can be a game changer in terms of pain and the quality of our life. Certainly in terms of herpes zoster ophthalmicus, if you were to lose your vision or have a complication as a stroke, or even some of the rarer complications, that is something that is incredibly impactful. I had a patient who we talked year over year about her getting the vaccine. Every year I would document that I offered her the vaccine, and every year she would say no. And when I would ask her why, it really was not cost. She didn't perceive herself as being at risk. And we went through her individual risk factors that not only was her age putting her at increased risk, being female was putting her at increased risk. She had a family history of shingles, and she herself was diabetic. Yet she still did not perceive herself as being at increased risk and thought that she had lived all these years without any problem and it wouldn't be a problem. And in fact, within 6 months after our last visit, she came down with herpes zoster ophthalmicus and lost her vision in one eye. And she came back to see me and said, despite everything you told me, I just didn't think that this could ever happen to me. And the answer is that I don't have a crystal ball. I don't know who this will happen to, but I do know, looking at the odds as we age, it increases with age. There's no turning back the clock to management of this chronic pain or the potential other impacts that it can have. So I want you to know that there is a safe and effective vaccine strategy that is available for all of us in terms of what it is we're trying to protect. And I think that in terms of healthy aging, as my mom always said to me, It's not how long I live, it's how well I live. And for her, being able to live independently was the most important thing for her, and to continue to be socially connected with her family. Shingles and its complication can rob you of that. And I think that's something that you really need to think about, what the long-lasting complications could possibly lead to, and how in this day and age, we have such a safe and effective strategy in terms of vaccines that we can offer you.
Well, thank you so much, Dr. Shapiro. I don't think I could have said it any better myself. I don't think anybody could have said it any better. So thank you so much for joining us all today and celebrating Shingles Awareness Week. And as Dr. Shapiro said, get vaccinated and protect yourself against shingles. Thank you so much for joining us. It was a pleasure.
Thank you for having me.